start discussing on multiple sclerosis today, another neurology topic. So last time we discussed about GB syndrome. GB syndrome is also a sort of autoimmune disorder directed against myelin, but that is the myelin of peripheral nervous system. That is the nerve roots and the peripheral nerves. But in contrary to that, multiple sclerosis is actually again another autoimmune disorder directed against myelin only, but of the central nervous system. So it's a central nervous system disorder, multiple sclerosis, important from a number of aspects. Theory exam, yes, there are some questions that could be asked. It's definitely important from entrance exam point of view. It's also important from practice point of view and your practical exam point of view also. So that's why we'll discuss multiple sclerosis today. Some questions that have been asked are long essays as well as sometimes short questions on drugs used in treatment of multiple sclerosis. Management of MS is important, including investigations and obviously the treatment. So many treatment pharmacological agents are available for treatment of multiple sclerosis. So that's why important to know. It's an important topic. Getting on with the discussion, as I said, it's an autoimmune disorder affecting the central nervous system. And where exactly is it affecting? It's affecting the myelin. Okay, so it is the myelin that is the target of the autoimmunity in multiple sclerosis. It is a combination of cell-mediated and humoral autoimmunity. It's not just autoantibody mediated. It is also predominantly cell mediated. So cytotoxic T cells, the CD8 T cells, they are found in large numbers within the central nervous system of patients with multiple sclerosis. Why is what is the reason why it's called multiple sclerosis? Very important. Sclerosis is of course because of astrocyte proliferation. So astrocytes will lead to, eventually it will lead to fibrosis. So sclerosis here is because of fibrosis. That means the part of that CNS has become dead. Only if it is dead, then it will be fibrosed. So the dead tissue is fibrosed, and that's why sclerosed. Okay, but multiple, because at multiple sites. Now this multiple is very, very important in multiple sclerosis, especially for diagnosis. Whenever you want to entertain the possibility of multiple sclerosis as a diagnosis for a neurological disease or a neurological symptom or manifestation, you should have this multiple. Multiple meaning disseminated. Disseminated, where disseminated in time and space. It's called dissemination in time and space. That means this autoimmune disorder should have produced multiple lesions in different sites and across different time periods. So at the same time, if there are multiple lesions, that will not qualify for multiple sclerosis. Likewise, if there is, if a patient has the same lesion getting aggravated at different times, so if there is relapse and then again remission, relapse and then again remission, the same lesion, the same deficit is repeating multiple times, it still won't count as multiple sclerosis. So for example, if a patient complains of blurring of vision because of optic neuritis, but the person's optic neuritis somehow resolves, and after a variable period of time, again, the person has the same symptom, the same blurring of vision. So the same lesion, the same eye, perhaps only in one eye. So optic neuritis is repeating, and no other new deficits are there. No other new deficits are there. Even though the person had multiple episodes over multiple episodes of the same deficit, same lesion over the different periods of time, it still won't count as multiple sclerosis. So you have to demonstrate that there are multiple lesions demonstrated across different time and space dimensions. Okay, so this is a very, very important point when you are going to make the diagnosis of multiple sclerosis. Though it has an autoimmune basis, it doesn't seem to always go in a progressive manner. So that's why 90% of the times it will be relapsing remitting type or relapsing type. Now we don't say relapsing remitting also. Just a relapsing type of multiple sclerosis is 90%, constitutes for 90% of all MS cases. Only 10% constitute for progressive type, where there is the same lesion that continues that continues in time. Okay, so I'll tell you about the subtypes of multiple sclerosis also. Focal lesions. So basically, there are multiple focal lesions which occur in different periods of time that you have to prove. For making a diagnosis of multiple sclerosis, you have to prove this multiple lesions, that means dissemination in time and space. Okay. Yeah. So as I was saying, 90% of the times it's going to be a relapsing remitting course. That means, supposing if we plot the deficit against time, if you prepare a graph, in the case of relapsing multiple sclerosis, it will start out at a certain deficit and then it'll suddenly bump up. Okay, there'll be an attack, a new attack, and then the attack deficit will come down. Whether with treatment or spontaneously, the deficit will come down. And then again, it will go, it will reach a new baseline. So to start out itself, they may not be normal. They would have had already some deficit at baseline. So at baseline itself, some deficit is there. Then there's a new attack which pushes the deficit up. So the deficit increases. And then after that, deficit sort of resolves. So the patient status returns to a new baseline. The new baseline is still not the same as the old baseline. So it's still higher than the previous baseline. So the deficit has actually increased. It had suddenly increased. It came back. It reduced to an extent, but not to the previous level of deficits. It's still a new baseline. Okay. Again, for some time, there'll be quiescence. The person doesn't have any new symptom, new deficit. Then again, there may be another attack where the symptom gets exacerbated more. And again, it returns to a new baseline. So gradually over time, there is going to be some amount of progression. This is what we observe. Even in the relapsing type, we don't say that it is, we know that it is not going to stay at a fixed baseline. There is going to be eventual progress, but the progress is very slow. So that is why the person may not appreciate that progress until a long time has passed. Okay, so there will be a baseline that is established. Every time there's an attack, the person has exacerbation of the symptom or a manifestation, and then the attack resolves. That time they'll return to a new baseline. Okay, and so that means with time, with each attack, there is going to be an added deficit to the baseline. That's the relapsing type. Instead, if in case the person has a constant progression like this, the person ends up having constant onset. Since onset, the disease is just progressing. The deficit is just progressing with time. So this kind of a progression is primary progression. So this is a relapsing. This is a relapsing. If in case there are intermittent relapses and then remissions. Instead, if there is a continuous progression, then it is primary progression, primary progressive MS. Whereas, if in case this relapsing course itself, this kind of a pattern where there was initial relapse and remission, relapse, remission, this then suddenly becomes progressive. That is called secondary progressive. So a relapsing MS may turn into a secondary progressive also. So these are the different broad subtypes of chronic multiple sclerosis. Remember, multiple sclerosis, most often it is a chronic disease. It's a chronic disease. Very, very rarely it will have an acute or fulminant course. There are certain times where it is fulminant, but most often it will be chronic. In that chronic also different patterns. Either they have intermittent relapses, remissions, with the baseline also never coming back to normal. They'll never be symptom free. They'll still have baseline deficits, and each attack, there will be some addition to the deficit, baseline deficit. Yet they tend to, overall progression is still slow. Okay, overall progression is still slow. Whereas in primary progressive MS, right from onset of symptom, as the time goes, the deficit continues to continuously increase. So that is called primary progressive MS. If in case an initial relapsing remitting course gets converted into a progressive disease, that's called secondary progressive MS. Okay. Most often this primary progressive MS will affect the spinal cord. Okay, so it takes a strong suspicion to be able to make a diagnosis of primary progressive MS, because when they're having this kind of a relapsing remitting course, it's easier. But when they have a primary progressive disease, to suspect that it must be because of multiple sclerosis, that's not the first thought usually. Usually we think of other progressive disorders, but you should also keep in mind maybe the rarer form of multiple sclerosis if a person is having a new deficit that is progressive with time. So these are the 3 chronic types, whereas we have 2 other more aggressive forms, more acute forms. One is the Marburg variant, which is a fulminant type of MS. So a patient can end up having this kind of a progressive course, so progressive that the graph will be like this. Okay, so the deficit is just within a matter of days, the deficit is increasing at such an alarming rate that it is life-threatening. It is life-threatening. So person may have fatal outcome. Likewise, Ballow's concentric variant is also very acute. This is characterized by very large demyelinating lesions, which are present in the brain or the spinal cord, So remember, it's only a CNS disease. So in case of multiple sclerosis, it's only a CNS, only the central nervous system that is getting affected, unlike in GB where it is purely the peripheral nervous system. But it could be the brain or it could be the spinal cord. And remember, it's demyelinating. So that is why even if it affects the spinal cord, it will mainly be the myelinated fibers that are affected. Myelinated fibers meaning posterior column and corticospinal tract, pyramidal tract, corticospinal tract. Okay, so these are the different subtypes, clinical subtypes based on progress and based on onset and eventual progression with time in case of multiple sclerosis. So what are the risk factors? So how you can remember the risk factors of multiple sclerosis are A, B, C, D, E, F, G, H. Okay. A is for age. Usually it affects women. That means I'll come to that also, female gender. But it usually affects women in their 20s to 40s. So anytime a person has a new neurological deficit, a new onset neurological deficit below the age of 15 or over the age of 60, you will doubt whether it is because of multiple sclerosis. Okay, because the age group most commonly is between 20 to 40 years. Okay, young lady who has a new deficit, you can suspect, definitely you can keep a suspicion of multiple sclerosis. Lack of UVB radiation exposure. So this is again directly linked to another factor, that is vitamin D. So you know that vitamin D synthesis occurs best when the skin is exposed to UVB radiation. And this is generally found between, in India at least, it is found between the time periods of 10 a.m. to 2 p.m. maximum UVB radiation. So for vitamin D synthesis, if there is lack of UVB radiation, then again, it is said to be a risk factor for development of multiple sclerosis. Cigarette smoking also has been said to be a risk factor for multiple sclerosis. So young women who end up smoking cigarettes, they have a greater risk for developing multiple sclerosis in future. So I may be saying women, but it's not that only women develop multiple sclerosis. Majority of patients of multiple sclerosis are women, but men can also develop. So we have to have a high index of suspicion. Vitamin D deficiency has been shown to be strongly associated with the multiple sclerosis. Okay, so that is why UVB radiation, high latitude, all important for are important risk factors for multiple sclerosis. Vitamin D deficiency has been noted to be. In fact, in treatment of multiple sclerosis, it is suggested that vitamin D be supplemented. So vitamin D supplementation is suggested for patients with multiple sclerosis. Not that it has any disease modifying effect. It is just an additional therapy. No harm, no. So that's why if they are found to have D deficiency, better to supplement and correct their vitamin D levels. Epstein-Barr virus infection, very, very important. This has been very strongly noted that patients who have had a past history of Epstein-Barr viral infection, they have been seen to progress to develop multiple sclerosis. That's why there's a lot of research right now to try and develop Epstein-Barr virus vaccine or vaccine against Epstein-Barr virus. So that that's in the West. Actually, I did not mention this, but it's multiple sclerosis is much more common in the West. So Caucasians tend to develop multiple sclerosis much more than, let's say, Asians or Africans. Okay, so somehow Caucasians seem to have a higher predilection for development of multiple sclerosis. So that's why there's a lot of interest in trying to develop Epstein-Barr viral vaccines. And you know that Epstein-Barr virus is notorious for its association with number of diseases. For example, multiple sclerosis. For example, SLE also, and unfortunately, a lot of malignancies, a lot of tumors. Can you guys name any tumors that are associated with Epstein-Barr virus infections? Any tumors which are linked to Epstein-Barr viral infections? So many are there actually. Anybody? Okay. So some of the infections include Hodgkin's lymphoma, and there are subtypes of non-Hodgkin's lymphoma also. Subtypes of Hodgkin's lymphoma which itself can be associated, including the nodular sclerosis, including the lymphocyte-rich and mixed cellularity. All of these have certain amount of association with the Epstein-Barr virus. Non-Hodgkin's lymphoma also has association, including diffuse large B-cell lymphoma, has a strong association with Epstein-Barr viral infections. So likewise, multiple sclerosis also has a strong association. That's why if it's possible to achieve control of this virus, maybe the incidence of multiple sclerosis will come down. Okay, female gender, most autoimmune disorder, this being an autoimmune disorder, and in case of autoimmune disorders, most often it's women that are affected. This is no different. Okay, and genetic. So HLA associations, HLA-DR15. So HLA-DRB 1501 to be most uh, precise. But HLA-DR 15, you can remember. This is what is said to have a greater risk for development of multiple sclerosis. And then high altitude, maybe to do with the UVB radiation exposure and vitamin D synthesis. So the high latitude means the more, let's say, countries which are not near the equator. So you know that in the globe, the countries which are located near the equator, like India, India is not so far from the equator, no? So that's why the countries which are close to the equator, tropical countries, the incidence of multiple sclerosis is said to be less. Whereas those countries like Australia, or that is in the southern hemisphere, or let's say Europe, which is quite far away from the equator, these are called temperate countries. We are tropical, they are temperate. So they have been shown to have a greater incidence of multiple sclerosis. Okay, so perhaps to do with the vitamin D exposure. So what exactly is happening in terms of pathogenesis? There's going to be myelin breakdown. The first thing that happens in uh, multiple sclerosis is that the myelin is going to be targeted. And as the myelin is getting broken down, there will be some attempts at remyelination. So the oligodendrocytes, in case of GB syndrome, it is the Schwann cells, but in because that is peripheral nervous system. So here it is oligodendrocytes, which will get activated, which will try and attempt remyelination. So the myelin is getting broken down because of an autoimmune reaction. It may be a combination of cell-mediated plus humoral destruction of the myelin. So plus a combined effect will lead to myelin destruction, and that noticing that kind of a destruction, the oligodendrocytes may attempt remyelination, and these will all be evident on MRI. When you do the MRI, the loss of myelin will be noticeable as T2 hyperintensities, whereas the remyelination, attempted remyelination, will be visible as something known as shadow plaques. So these are MRI findings on MRI. Okay, so but basic problem is the myelin is getting targeted, Is it only the myelin that is getting targeted? Is the gray matter free from, uh, uh, or rather, are the axons free from any damage? No, they are not free. Eventually, from myelin, it will also end up affecting the axons. So there is going to be axonal degeneration also eventually. It begins with the myelin, but will end up affecting the axons also. And as long as there is a significant myelin targeting or myelin level damage, there can be reversal of, or to an extent, there can be improvement in the symptoms. But once the axons get degenerated, they will end up having more permanent manifestations. So remember, axons, once they're damaged, the recovery capacity is very, very low in the central nervous system. So axonal damage will lead to more permanent manifestations. Myelin, as long as it's only the myelin level, then it can be reversed. It will respond better for therapy. As well as in general, spontaneous recovery is also better chance. Okay, there is going to be mainly the perivenular sites which are getting affected, and loss of blood-brain barrier can be noticed. That is why when you give them gadolinium, when you give gadolinium to such patients in active lesions, no, the gadolinium you all know is the contrast used for MRI. So when you're performing an MRI, if you want to do a contrast enhanced MRI, the contrast that is used is gadolinium. That will leak. In an active multiple sclerosis lesion, when there is a loss of blood-brain barrier, the gadolinium dye will extravasate. So it will start showing up. It will extravasate from the blood. It will enter into the CNS tissue. So it will start showing up on the MRI that you can see the gadolinium leaking out. So this is an important tool to make a diagnosis of active lesions. So sometimes what happens when you do an MRI, you may see multiple lesions on the MRI. How do you know whether it's an old lesion or it's an active lesion? Can you attribute the current deficit, the patient's neurological deficit? Can you attribute it to that particular lesion? Only if it is active. So how do you prove it's active or not? You give them gadolinium and see if it leaks. If it leaks, then it's an active lesion. That's because the blood-brain barrier has been disrupted. Okay, and finally, there is going to be astrocyte proliferation, which will be responsible for the gliosis, which is nothing but fibrosis. Astrocytes, finally, they are glial cells which are modified fibroblasts. So that's why they will end up promoting fibrosis, leading to the gliosis. Okay, gliosis basically means thickening in the nervous system. Okay, so it's a combination of cell-mediated immunity and humoral immunity. That is why you will finally, when you go for treatment, no, you really want to target what the cells here, which cells you want to target. It's the lymphocytes, especially the cytotoxic CD8 T cells. CD8 T cells are the chief targets when you are going to initiate them on treatment. You want to target these CD8 T cells, and to an extent the B cells also, and the products of the B cells, which are antibodies. So these antibodies, which may also be causing direct destruction of the myelin and manifestations of multiple sclerosis, you want to reduce these antibodies. And if the patient is having a fulminant or a very progressive course, you can try and go for plasmapheresis to remove these autoantibodies. So when you go for plasmapheresis, you may be able to remove these autoantibodies and be able to relieve them from their symptoms. For example, in patients with as I said, Marburg variant, a very fulminant fulminant course of multiple sclerosis, you may be able to offer them treatment with plasmapheresis to remove the autoantibodies. Okay, so next, coming to clinical features. So what set of patients will you suspect patient to have multiple sclerosis? Remember, it is a CNS disease. So automatically, anytime there is a peripheral nervous system manifestation, anytime that you see patient having fasciculations, or you see patient is having hypotonia, may be there sometimes. I mean, because of neuronal shock, you can't rule out hypotonia. But fasciculation, definitely a lower motor neuron manifestation. Atrophy of muscles is definitely a lower motor neuron manifestations. manifestation. So any element feature for that matter, if you are making a diagnosis of a lower motor neuron lesion to account for the neurological manifestations in a particular patient, then you will have to rule out multiple sclerosis, because MS does not lead to LMN. It leads to UMN features. Okay, it need not be only motor, of course. Okay, most often it is sensory only. The manifestations in multiple sclerosis are, majority of the times it is sensory, and to an extent some motor manifestations. But anytime you get a lower motor finding, then it is not MS. Okay, so now coming to individual parameters in terms of sensory involvement, very often they have these paresthesias. So the feeling of pinpricks and tingling in their extremities. So a lot of times what we think, okay, if a patient is complaining of tingling, person must be having a peripheral nerve issue. But no, even in multiple sclerosis, there can be central nervous system cause for paresthesia. So please remember, paresthesias can occur in peripheral neuropathy also, but also occurs in multiple sclerosis. In fact, it's a prominent manifestation. Tingling of the extremities. It's a very common manifestation in patients of MS. They can have loss of sensation. So loss of sensation is also, that means an objective on testing, on sensory examination, you'll notice that they are having loss of sensation. So it's an objective sign, clinical sign. This is important. Okay, and upper level of sensory loss. Upper level of sensory loss will indicate only and only one lesion. Remember I told you that how do you localize the lesion in neurology? You localize it based on what are the manifestations, what are the clinical manifestations or clinical deficits. If the person complains of there are certain pathognomonic features, or let me say there are certain very classical features which will have no other localization. One of those is a definite upper level of sensory loss. So in the body, from inferior to superior, when you are testing for sensations, you find that all the sensations are intact above a certain level, but all are lost or diminished below a certain level. This means that there is an upper level of sensory loss in the body. It can only be localized to a lesion in the spinal cord. Anytime a patient has a spinal cord lesion, they will have an upper level of sensory loss. They will also have something known as girdle-like sensation. Girdle-like sensation, band-like sensation. These terms always mean spinal cord. It cannot be anywhere else. It cannot be in the brain. It cannot be in the peripheral nerve. It cannot be in the muscle. If a person has muscle anyway, no sensory manifestations. But if a person is noted to have on examination, noted to have an upper level of sensory loss, it's the spinal cord that has been affected. Okay, and spinal cord, which sensory fibers are myelinated? It's the dorsal column, posterior column or dorsal column, which has fine touch, right? Fine touch is conveyed by posterior column. So it's a spinal cord lesion. Pain, very, very prominent manifestation, pain. Okay, it could be the limb pain, it could be the girdle-like sensation pain, it could be Lermit sign, that is in the neck pain. Okay, that's what I mentioned, Lermit sign also. Lermit sign you get when a person with multiple sclerosis who has cervical cord lesion, posterior column lesion, when they flex their neck, they will end up having a lightning. It's almost like a bolt of lightning, very transient, very brief pain, but it's like an electric shock like pain, and very distressing, but fortunately very transient. But they're scared after that. They don't want to move their neck also. It's very uh, uh, uncomfortable and very debilitating pain. Okay, so this occurs when there is a cervical spinal cord lesion in the posterior column. So in the dorsal column, when there is a lesion at the level of the spinal cord, in the cervical spinal cord, then when they flex their head or flexion of the neck, then they'll have this shooting electric shock like pain. That's called Lermit sign. Okay. This again is very, very specific. If a patient complains of Lermit sign, the lesion is in the cervical cord, that too in the posterior column. That is given. You cannot place it anywhere else. You cannot explain, you cannot justify this particular symptom by placing the lesion anywhere else anywhere else at all in neurology. Likewise, this also you can't place it anywhere else apart from spinal cord. And the level of lesion will decide which part of spinal cord. If it's in the umbilicus, then it's the thoracic level. Okay, so most often it is the thoracic level that is affected on. That's about sensory manifestations of multiple sclerosis, which are usually very prominent. More than motor, it will be the sensory that are very prominent. But you also need to try and detect. They may not complain also sometimes. So the loss of sensations, they may not have perceived. They might have had eye symptoms and they came to you for blurring of vision. But when you are testing sensory examination, you'll notice that there is loss of fine touch or loss of proprioception, which means they are having objective sensory loss. So you have to try and uncover, or you have to discover these manifestations on examination, even if the patient doesn't complain. Motor, yes, it will lead to spasticity, which is a big problem. Spasticity because of upper motor neuron lesion, no? So upper motor neuron lesion. So it's going to lead to hypertonia. And that spasticity, what it do? It will make them tired. They're having to put effort all the time to try and even make a simple movement. They have to try and overcome this hypertonia and resistance. So they end up feeling fatigue. So fatigue is a very common manifestation, especially as a result of spasticity in multiple sclerosis. So if you can relieve this spasticity, their fatigue also will improve. That's how it is. That's as a result of UMN, upper motor neuron lesion. Okay, so weakness, of course, will be there. They will have weakness, but their spasticity will bother them a lot more than their weakness. In the initial stages, you know what happens? Because it's an upper motor neuron lesion, the motor units which are not affected will try and compensate for the affected UMN fibers. So whichever fibers are affected, the other fibers will try and compensate for the weakness. So the weakness is more towards later part of the disease, when the pyramidal tracts or the corticospinal tracts are affected. But it's a lot of spasticity that gives them trouble. That's why you try and treat this by giving baclofen and muscle relaxants, tizanidine. You try and overcome the spasticity by giving muscle relaxants like baclofen especially. So motor manifestations could be seen in multiple sclerosis. Cranial nerves, especially second nerve. So very, 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 very important. If you are making a diagnosis of multiple sclerosis, it is said that the patient must and should have optic neuritis or some form of optic nerve manifestation. It may not be the patient telling you that they are having blurring of vision or pain. You may have to try and find that out either on test examination, or you may have to do imaging like an MRI. MRI can show the optic nerve swollen up, or you may have to uncover it on visual evoked potential, something called visual evoked potential. Visual stimulation, and then you're testing whether the optic nerve is functioning or not. When a visual stimulus is given, did the optic nerve fire normally or not? So visual evoked potential, very important, because you can try and pick up a lesion where the patient is not complaining and examination is also normal. Okay, because the lesion may be retrobulbar, no? Optic nerve may be getting affected behind the level of the retina. So if anything is behind the retina, you cannot try and find it out on ophthalmoscopy. Maybe the patient also doesn't have clear-cut symptoms yet, or may not have symptoms. But how do you prove that it is because of optic nerve that is getting affected? So in that case, you can do a visual evoked potential, or you can try and do an MRI and see for swelling in the optic nerve. So on a frontal plane image or frontal section, from the frontal section, meaning you're looking at it from the front. So if you can get an MRI frontal section in the frontal plane, you may be able to notice the optic nerve, and you can compare. In multiple sclerosis, usually only one side is affected. So multiple sclerosis, usually optic neuritis is unilateral. Very, very rare for it to be bilateral in multiple sclerosis. If a patient has bilateral optic neuritis, instead of MS, if it is bilateral optic neuritis, before MS, you should suspect other diseases. For example, neuromyelitis optica. Neuromyelitis optica has a greater chance of producing bilateral optic neuritis than multiple sclerosis. Okay. Yeah. And internuclear ophthalmoplegia. You guys, I hope you know what is internuclear ophthalmoplegia. We discussed this, I think. In stroke, we discussed it, no? So internuclear ophthalmoplegia is when the medial longitudinal fasciculus is affected. So lesion affecting the medial longitudinal fasciculus. So as the name suggests, internuclear. So between two nuclei, there are some fibers. And if that gets affected, the person will have internuclear ophthalmoplegia. So which are the two nuclei which are between which the fibers are running? It is the contralateral. I'm saying contralateral with respect to the fiber. Okay, so let us say this is the right MLF. Okay, so this is the left sixth cranial nerve. This is the right third cranial nerve of oculomotor nerve, which will make this as the right MLF. Remember, the MLF is named after the third nerve to which it's supplying. So right or left, because it has to cross the midline. This is the midline. It has to cross from one side sixth nerve. It has to go to the opposite side third nerve. Now that means it has some component on either side of the midline, but we deem it to be the same side as the third nerve that it is supplying. Why do we need this kind of internuclear fiber? Because muscles like lateral rectus and medial rectus, they are conjugate muscles. They are yoke muscles. They have to act together. So if I have to turn my gaze to my left, my left sixth nerve has to stimulate my left lateral rectus for it to abduct. But at the same time, it should coordinate with the right medial rectus. The left lateral rectus and right medial rectus have to contract together for me to be able to look to the left and turn my gaze to the left. So that is coordinated by this medial longitudinal fasciculus. It is such a small fiber, this medial longitudinal fasciculus, such a fine fiber, one thin strand of connection between two cranial nerves, cranial nerve nuclei. So imagine if there has to be a lesion that is affecting only this one fiber in the entire brain, if you are getting only this as a lesion in the entire brain, so much of gray matter, so much of white matter, so many fibers, so many nuclei, but the lesion is only the medial longitudinal fasciculus, one small fasciculus over here, somewhere at the level of the between. So this is sixth nerve is in the pons, but third nerve is in the midbrain. So it's between the pons and the midbrain. One small fiber is running, and that is getting affected. Nothing else around it. So if it was a space occupying lesion, it wouldn't produce only that. No, it would produce other lesions also. Or if it was a stroke, you won't expect only this nerves or this fascicles blood supply to be affected. It must be a very, very small artery. If that is getting affected, surely there'll be some branches also for that particular artery. It will have other manifestations also. But no, if only that one fascicle is affected, you have to first think of multiple sclerosis. The myelin around that nerve got targeted in that particular episode, and that is why the person developed internuclear ophthalmoplegia. Okay, so internuclear ophthalmoplegia is very, very, it points very much towards multiple sclerosis being the cause. Yes, technically a stroke can also cause it. Very, very small stroke could also lead to, I know, no arguing that, no debating that. But the more likely possibility is multiple sclerosis, if only the MLF is affected. Then there are certain other manifestations where there's something called 1.5 syndrome. So in the case of 1.5 syndrome, there will be a lesion that affects the medial longitudinal fasciculus of one side, and it will also affect the parapontine reticular formation of the other side. So basically, they will have a loss of the only possible movement will be just the abduction of one side. So abduction being possible, adduction being possible only on one side, where the person has a preserved sixth nerve. Okay, so abduction being possible because of sixth nerve being preserved on one side. That where only the MLF is lost. The other side, parapontic pontine reticular formation lesion will take out both the sixth and third nerve. The other on one side, only MLF is there. MLF is lost, and sixth nerve is preserved. So only abduction on one side will be preserved. Adduction on that side and adduction abduction both on the other side will be lost. So that's why 1.5 lesions, only half the eye movement will be preserved. Only abduction on one side will be preserved. So this again could be because of multiple sclerosis. If this is in addition to seventh nerve being paralyzed, then it is called 8.5 syndrome. Okay. So seventh plus 1.5, that's 8.5 syndrome. Now, these are not so typical of multiple sclerosis. These can occur in MS also, this can occur in stroke also. But then only MLF being lost, then it is most likely multiple sclerosis. Okay, otherwise you can get trigeminal neuralgia manifestations as fifth nerve being affected. So these are the third and sixth nerve, or rather the third nerve being affected, second cranial nerve being affected, fifth cranial nerve, seventh cranial nerve, facial myokymia. Patients may have certain eye flickering of the eye muscle, orbicularis oris muscle. I'm sorry, orbicularis oculi muscle. So that kind of a flickering in the muscle because of motor fibers being affected in multiple sclerosis could also occur. Okay. So there can be cranial nerve manifestations. Other manifestations include genitourinary, very, very common. So eye manifestation, very common in MS. Bladder, urinary bladder manifestation also very common in MS. So detrusor, sphincter dyssynergia. So the person's detrusor is contracting, but the sphincter is also contracting. Both should not contract together, no? If one has to void urine, then the detrusor should contract and the sphincter should open up or relax. Likewise, if one has to hold the urine inside, the sphincter should contract and the detrusor should relax. But if both are contracting together, it is going to lead to neither the urine is able to come out nor the patient is able to hold the urine back easily. So the person may want to pass urine, but it's not coming out. That's called detrusor sphincter dyssynergia. So a loss of coordination between the two sets of muscles. And sometimes there is just detrusor hyperactivity or hyperactive detrusor. So a patient may have very high frequency of micturition. And genitourinary, so even impotence is a very frequent complication or frequent feature of multiple sclerosis. So these are genitourinary manifestations. Remember, bladder, neurogenic bladder is very common. Neurogenic bladder and optic neuritis, both are common in multiple sclerosis. Okay. So basically sensory, motor, cranial nerve, genitourinary, and then there are others. Like they can even have cognitive decline. So they may have certain amount, though this is a gray matter. Technically it's gray matter, but there can be subcortical dementia. There can be subcortical dementia in multiple sclerosis. Subcortical level, there can be dementia. It may not be frank dementia. It may just be cognitive decline, not yet impairing their functioning. Depression is a very, very common accompaniment in multiple sclerosis. They will have depression, and as I told you, they'll also have fatigue. So cognitive decline, depression, and fatigue especially because of spasticity. And it may also affect the, okay, before the next point, UTOF phenomenon is important. UTOF phenomenon is where there is an increase in the neurological, in an old neurological deficit, there is an increase. Okay, so increase in neurological deficit in an old or already established, okay, established neurological deficit will increase. So it should not be a new deficit, okay. And this happens in response to exposure to heat, or sometimes the body temperature only increases. So during fever, during infection, during a hot shower, a particular deficit. Previously only the deficit was there. There had been a relapse. Now patient was in remission because of exposure to heat, temporarily, transient. Okay, it's a transient increase. There's a temporary increase in the deficit. So how temporary are we talking? 24 hours. You should not cross 24 hours. Less than 24-hour increase in a now already established or previously occurred deficit, that is called Uthoff phenomenon, when it occurs in response to exposure to heat. Okay. So this is a very typical manifestation of multiple sclerosis. And as I said, there could also be a technically it's not non-neurological, because remember, ADH is secreted from where? ADH is secreted from where and stored where? Antidiuretic hormone is secreted from where and stored where? Antidiuretic hormone. So it's stored in the neurohypophysis. Neurohypophysis is nothing but the posterior pituitary. So that's why it can get affected and can lead to inappropriate secretion of or inappropriate release of ADH from the neurohypophysis. So they can end up having SIADH. SIADH is possible in multiple sclerosis, but it is secreted, remember, from the hypothalamus, only stored, and it is transported across via the pituitary stalk to the posterior pituitary, from where it is released only in response to, mainly in response to osmolality of the blood. If the osmolality of the blood is going to rise, that time ADH is secreted. Antidiuretic hormone. It wants to oppose diuresis, oppose the loss of fluid. Wants to reduce the urination so that fluid is retained if the osmolality is increasing. Okay, so but here, even if the osmolality is not high, because multiple sclerosis can lead to antidiuretic hormone secretion, it will lead to SIADH. Okay. There are other non-osmotic stimuli, including pain. So patients of multiple sclerosis will have pain. That is why they'll have ADH secretion. So that is one reason why they can have SIADH. Okay, and they can have other autoimmune disorders. So because MS, HLA, DR15 association is there, that's why they can also have other autoimmune disorders, whether it's skin vitiligo or celiac disease in the intestines, or even lupus. That's rare. Lupus is rare, but they can have other autoimmune disorders in association, which may be another clinical feature that you can notice. Okay, coming to how do you diagnose multiple sclerosis? Two things you should know. There are two terms: attacks and objective clinical evidence of lesions. So clinical attack is when the patient gives you the history. It's the history that the patient gives you. Whereas objective clinical evidence is what you find on examination. So basically, attack is symptom and objective clinical evidence is a sign that you elicit on examination. Okay. These are the terms that you should know. Now, coming to diagnosis, you have to demonstrate that there has been there are lesions with dissemination, which are disseminated in space and time. Okay, time and space. There has to be dissemination in time and space. That means at least two lesions should be there, which should have occurred at two different periods of time, two different time intervals. Okay. I hope this is clear. Dissemination in time and space. Now, let's say first scenario, a person has two or more clinical attacks. The person says, I had blurring of vision before, and now I'm having, now the person is having INO. So earlier there was blurring of vision. Now the person is having an internuclear ophthalmoplegia, and that's why it's causing diplopia. Okay, maybe that's not a best example. Maybe initially the person had blurring of vision, and now the person is having Lermit sign. So that means it's localizing to the spinal cord. So two different lesions at two different time points, which means the person already has dissemination in time and space. So two or more lesions at two different times means the diagnosis does not technically. This is called McDonald's criteria. Okay, the criteria name of the criteria for multiple sclerosis is called modified McDonald's criteria. This is the latest revised version from 2017. Okay, according to the McDonald's criteria, if any individual has two different lesions, either in terms of clinical attack history or objective evidence on examination, which have occurred at two different time points, then the person can be deemed to have multiple sclerosis without any additional investigations. But practically, you will not be able to do that. No, you still have to convince the patient also and convince yourself also that the patient has MS. So practically speaking, you still do an MRI or you might do a CSF just to make sure that you're right in diagnosis of MS. But the criteria doesn't mention that. But keep in mind, practice, you have to be more careful because it may be a different diagnosis. It may be sarcoidosis. You are thinking that it is multiple sclerosis. It may be sarcoidosis. It may be vasculitis. These are differential diagnoses. CNS vasculitis or CNS neurosarcoidosis. These are differential diagnosis. Neuromyelitis optica is a differential diagnosis. So you can't take chances. You will still do an MRI or you'll do a CSF analysis. But remember, two different attacks or two different clinical manifestations occurring at different time points is enough to make a diagnosis of multiple sclerosis without any further investigation, according to modified McDonald's criteria 2017. Next, if the person has two different clinical attacks, but right now only one examination finding. So person said they had blurring of vision earlier, and right now they are having Lermit sign. So on examination, you are finding that yes, cervical cord, some maybe they are having cervical cord uh, up to the level of cervical cord, there is sensory loss. Fine touch is lost till the cervical cord level. Okay. But how do we know that the blurring of vision, the previous attack where he said he had blurring of vision, then it subsided, now his vision is fine? How can you prove that that was also because of multiple sclerosis? You have to prove dissemination in space. So you need to do either a visual evoked potential or you need to do an MRI and prove that the optic nerve has evidence of a previous attack. Okay, you have to prove that there was a previous attack that affected the optic nerve. So in case the patient has history of two attacks, but right now only evidence of one lesion on examination, you need to prove that there was a previous attack, dissemination in space in a different site. So either you wait for an additional attack to happen, or you can do an MRI. And by doing an MRI, you may notice that there is an optic nerve thickening, or you may notice a different lesion elsewhere. So if there are two or more lesions, that proves that there is dissemination in space. When there is definite history of history of two attacks, but evidence of only one clinical evidence of only one deficit. Okay, that is if the scenario is like this. If the scenario is the person has had only one clinical attack, but there is evidence of two or more lesions, like I told you, sensory deficits may not be complained by the patient. Patient may not realize he has numbness somewhere. Only when you examine, you will notice, oh, there is sensory loss. Likewise, they may have some more obvious manifestations. So they have blurring of vision right now. And when you check for their vision, the visual acuity is reduced. And when you do a fundoscope, maybe you're noticing some changes suggestive of optic neuritis. So, okay, so optic neuritis is there on examination also. But on examination, there is a sensory loss. But the person didn't complain about that sensory loss. Person only complained of blurring of vision. So basically, you have history of one attack, but evidence of two or more clinical lesions on examination. In that case, you need evidence of dissemination in time. So for dissemination in time, you can use three methods. Either you wait for an additional attack, wait till the next attack involving a different territory, different area, or you'd use gadolinium. So when you do MRI, you can use gadolinium to prove that there is gadolinium leakage. Remember, I told you gadolinium leakage means there is an active MS lesion, blood-brain barrier has been disrupted. That you can use to prove dissemination in time. Or you can do a CSF and detect something called oligoclonal bands. Oligoclonal bands are nothing but immunoglobulins. Okay, immunoglobulins, gamma globulins. So gamma globulins, if the fraction is high in CSF, That means humoral autoimmune response is more in the CNS. That can also give you, and it won't suddenly rise, no, it won't rise suddenly. It will rise over time. So if you are getting evidence of elevated IgG in the or oligoclonal bands in the CSF, it proves that they have been there for some time. So that will give you an idea that the person has had a dissemination in time. So remember dissemination time, three things: either you wait for the next attack or do gadolinium enhanced MRI, look for combination of enhanced and non-enhanced lesion. Some lesions are active, old lesions are also there. Old lesions will not leak. They'll be there on MRI, but they'll not leak. So that's why you will notice, you will be able to say that there are some active lesions, some inactive lesions, some old lesion. So old means dissemination in time. Or you do CSF and look for oligoclonal bands. That also will tell you that there have been previous attacks, and that is why the IgG levels are high, or immunoglobulin, gamma globulin levels are high in the CSF. Sometimes you may have only one clinical attack and only one lesion. So the same attack and same lesion is there. Then in that case, you have to prove both dissemination in space and dissemination in time. So you have to use both techniques. You have to prove both dissemination in space and dissemination in time. Whereas if there was one attack and two clinical evidence, then you needed to only prove dissemination in time. Ulta, two or more attacks, but only one objective evidence, then you had to prove dissemination in space. If you anyway had two or more attacks and two or more lesions objectively evident, then you didn't need any additional proof, but practically you'll still go for MRI. At least an MRI you'll do. If not gadolinium enhanced, just a plain MRI. Okay, but this is what is McDonald's criteria for the revised McDonald's criteria for diagnosis of multiple sclerosis. Okay. Basic crux is prove that there have been two or more lesions at two or more different time periods. And those lesions should be compatible with multiple sclerosis. Okay. They should be CNS lesions. So when we say MRI, there are certain areas where yeah, it's here, where you will deem them to be typical of multiple sclerosis. So these areas are four areas, that is juxtacortical, cortical or juxtacortical, mainly juxtacortical. You don't expect cortical lesion. Cortex is the gray matter. You don't directly expect gray matter lesions. Instead, you expect juxtacortical, just beneath the cortex. Okay. Or periventricular. Periventricular white matter, definitely. Corpus callosum. If the corpus callosum has a lesion, very typical of multiple sclerosis. Corpus callosum, you guys know, no? They are the interconnecting fibers between the two hemispheres. All white matter. That is fully white matter, corpus callosum. If that has a lesion, multiple sclerosis, very good chance. Very good possibility. Infratentorial white matter getting affected. Maybe the brainstem, the pons, the medulla, somewhere. Like I said, internuclear fiber getting affected. I know that is infratentorial. Or spinal cord. Okay, spinal cord white matter getting affected. So these four areas are typical areas of MS lesions. So if you are getting evidence of these, then you can consider it to be multiple sclerosis. So the kind of lesions also matter. It can't be incompatible lesions. Like I told you, LMN, patient has muscle atrophy, patient has fasciculations. These cannot be counted as objective clinical evidence. Okay. It has to be a compatible lesion, both clinically and on MRI also, radiologically also, in these four areas. One of these four areas should be affected. Okay. Now, that's what MRI, this is how it will be. This is a T2 weighted image, T2 MRI. In T2 MRI, the gray matter becomes white and the white matter becomes gray and the CSF remains white. Correct? But in the periventricular areas, you'll be able to make out certain hyperintensities. So T2 hyperintensities like this, there'll be sharp hyperintensities, okay? Sharply demarcated. This is unlike in NMO. NMO, it will be more cloudy, more diffuse. But sharply demarcated T2 hyperintensities this is periventricular. This is the ventricle and this is the periventricular area. So in such areas, or juxtacortical, just about here, juxtacortical, or infratentorial, that means in the midbrain, in the pons. Or if you can visualize the optic nerve, then in the optic nerve. So technically we say those four areas, the criteria says four areas. But if you can get a frontal image, the frontal section of the MRI showing the optic nerve, and if you compare and see that one side is edematous, that is also quite suggestive of a multiple sclerosis lesion. The optic neuritis is very, very suggestive of multiple sclerosis. Okay, so this kind of a lesion may be expected on T2 imaging in MRI. Remember those four areas: juxtacortical, infratentorial, juxtacortical, periventricular, infratentorial, and spinal cord. These four areas typical of multiple sclerosis. Very important. CSF, what are you looking for? Mainly you're looking for increased oligoclonal bands. They're called oligoclonal bands, nothing but IgG. So if there are two or more oligoclonal bands in the CSF, not in the blood. So what we do is you have to do a simultaneous blood, you have to draw a simultaneous blood sample and a CSF sample. Together you have to draw, send both for oligoclonal band testing. If you find that CSF has oligoclonal band but no oligoclonal band in blood sample, simultaneous blood sample, then it will favor a diagnosis of multiple sclerosis. That means those autoantibodies are there only in CSF. They're not spilling over from the blood into the CSF, which means they're getting produced in the CSF itself or in the CNS itself. And that means it is occurring over a period of time also. IgG does not come suddenly, it's initially IgM, only later it becomes IgG, correct? So if the patient is having IgG in the CSF, that means it's been there for a while. So this will also help you to prove there is dissemination in time. The lesion, the patient has had a problem for a long time. That is what it is proving, dissemination in time. Okay, visual evoked potential, useful when you're suspecting optic neuritis, but it's a retrobulbar neuritis. You're not able to see anything on fundus. The person right now does not have symptoms. It's improved. But you want to test whether the optic nerve is involved. You can't see anything on MRI. See, I told you second cranial nerve or looking for the optic nerve on MRI. If you can, then great. But it's not common. It's not easy also to make out the optic nerve on the frontal sections, frontal plane of an MRI. So instead, you can do a visual evoked potential. So visual evoked potential, it's called. Okay, that will show you whether the posterior part, retrobulbar part of optic nerve is affected or not. If it's not able to carry action potential based on visual stimulus, that means that there could be a lesion there. If there's a lesion there, it will go in favor of dissemination in space. You can use it for dissemination in space. There is an optic nerve lesion. The person has had another lesion somewhere else, then you can have at least dissemination in space. Okay. So this is the corpus callosum, and you can see these kind of projections from the corpus callosum. Corpus callosum is pure white matter. And if there are lesions that are affecting it and extending at right angles from it, these projections, what are they called? Any idea? Projections from corpus callosum. Any idea? Today everybody is quiet. Nobody's answering. Everybody's in Saturday mood. Okay. The projections like this, which are seen at right angles emanating from the corpus callosum in excellent. Alok has answered Dawson's fingers. We call Dawson's fingers. Okay. If you notice this on sagittal section, that means very, very likely that it is multiple sclerosis. Sagittal MRI, sagittal section MRI. Okay. See, this is the bulb. This is the globe. If you on sagittal section, you can't really make out the edema. It's best to try and compare it on frontal imaging. Once, you know what happened? A lady had come to our OPD. She had complained of tingling in her digits. Okay. In her fingers, only one side, one hand, fingers, there was tingling is what she said. So what would you think of? She was a software engineer. Lot of typing, lot of computer activity. So if a patient, if a person complains like that, I'm having tingling in these fingers. Yes, I'm using them a lot. I'm using it during my work and all that. Uh, what is the first thing that comes to mind? Any idea? Carpal tunnel syndrome. Excellent, Yash. So that is what you should suspect. If a person complains of either numbness or tingling paresthesias in the lateral 3.5 fingers. Okay. So if the 3.5 fingers are involved, the thumb, index, middle, and half of me, the lateral half of ring finger, you will think of carpal tunnel syndrome. The first thing you'll think. So what did we do? We thought it's carpal tunnel. We made her do the Fallon's test. This is called Fallon's test. Phallen. Fallon's test, like this. Ulta namaskara. This is the reverse Fallon test. This is Fallon's test. So then she said, yes, it's increasing. When I do like this, it's increasing. Okay, Fallon's test positive uh, this thing. Carpal tunnel syndrome is what we thought. Then always better to be on the safer side. So we sent her for nerve conduction study. It's a neuropathy. The nerve conduction must come back abnormal. So we told her, get the nerve conduction study and come back to the OPD afterwards. So she came for the next follow-up. And then the nerve conduction study was normal. So you cannot have a carpal tunnel syndrome. You cannot have a median neuropathy, median nerve neuropathy with the nerve conduction being normal. The sensory nerve conduction normal, motor conduction is normal, median nerve is normal in the nerve conduction study. That means what? That means the lesion is not in the nerve. It is proximal to that. It's a sensory lesion. Person's complaining of paresthesias. It's a sensory lesion. So next, what to do? It's either in the brain, it's in the spinal cord. Proximal to the nerve means where. So we asked her to undergo an MRI of the cervical spine. And the cervical spine MRI showed demyelinating lesions. So that made us suspect that she has multiple sclerosis. So for multiple sclerosis, this becomes there's one lesion. She has symptom and you have evidence on MRI for one lesion on the spinal cord. So which means you need one more. You need evidence of one more lesion disseminated in space and time you need, no? So at this time, she has only one lesion, which you have caught on MRI. And she has clinical findings also. But you need one more at least. And to prove that it has not occurred now, you need to show that there is another lesion, but it has not occurred together with this. It had occurred earlier. So for that, we did CSF and we sent for oligoclonal bands and we did oligoclonal bands from blood also. So you have to compare because rarely what may happen if there are increased IgG in the blood, it may spill over into the CSF. So how will you know that it is because of multiple sclerosis that the CSF has increased IgG? Unless you compare. So you compare with the blood. This lady did not have oligoclonal bands in the blood. She had it in the CSF. It's called IgG index. Okay, CSF IgG index, immunoglobulin G index. This is nothing but the ratio of, we say albumin globulin ratio, no? But IgG index is the globulin albumin ratio in CSF to blood. The same ratio in CSF to blood. And it turned out to be high. So she had oligoclonal bands in CSF on electrophoresis. So what you have to do is you have to do an electrophoresis of the CSF to demonstrate oligoclonal bands. Okay, otherwise you can just directly calculate the globulin to albumin ratio. If you have the quantity, what we did was the quantitative assay. We got the total amount of globulin to the albumin ratio determined in the CSF and compared it with the blood. We got a high value. So it's called IgG index. Since the IgG index was high, that was enough to prove dissemination in time. So she has other lesions also in the spinal cord. And along with that, we also did a brain MRI. So we had actually already done a brain MRI along with the spinal cord. That brain MRI picked up inactive lesions. So, we didn't give her gadolinium. We just did a plain MRI and that picked up lesions. We can't say it active or inactive without gadolinium. But basically, the brain MRI showed lesions. So now we had dissemination in space also. So there is a spinal cord lesion, there is a brain lesion also, and IgG is oligoclonal band is positive. So that means there is dissemination in time also. So based on that, she was diagnosed multiple sclerosis, and then she was started on glatiramar acetate. So it's a mild drug. So with glatiramar, she started improving. Okay, so that's how it can be. Sometimes it can present in a different way. Actually speaking, no, in medicine, almost any CNS lesion can be attributed to multiple sclerosis. Absolutely any CNS lesion, as long as it's not LMN. As long as it's not LMN. Okay, anterior horn means you can't. Anterior horn is also CNS. It's in the spinal cord, but you can't attribute anterior horn lesion to CNS. But anywhere else, any CNS lesion, you can deficit, you can attribute it to multiple sclerosis as a differential diagnosis. That's what is said. Uh, Before treatment, I'll just mention this. There's something called expanded disability. Uh, Expanded disability status scale, EDSS. This is the scale or it's a scoring used to determine how severe is the person's MS. And if the score is 4 or more, then treatment is very much required. If the score is less than 4, you can actually wait and watch. Okay, so if the score is 4 or more, definitely treatment is required. The person has a high chance for progressive disease, progressive relapses. So better to treat. Now, how to treat? One is take care of the acute attack. Suddenly there is an exacerbation. There is a either there's a new manifestation or the person has had an increase in their old manifestation. So it's an attack. And attack is defined as lasting for more than 24 hours. Remember, there can be certain transient manifestations like Lermit sign, like Uthoff's phenomena. Uthoff phenomena are also transient worsening of lesions. So you have to demonstrate, or you have to, the person has to have had the manifestations for more than 24 hours for you to say it is an attack. In that case, you can give them corticosteroids. So usually you give methylprednisolone, and depending on the severity, supposing the person had optic neuritis, sudden increase in the blurring of vision, lasting more than 24 hours, multiple sclerosis, you have to give them methylprednisolone. You give them pulse 500 milligrams over 3 days. I mean 500 milligram per day over 3 days. Okay, it's called pulse steroid therapy. This is to bring down the acute inflammation. And in case of fulminant, Marburg variant and all, if it's a fulminant attack, you can even go for plasmapheresis. So these are your options for acute attack treatment. Beyond that, how do you prevent further progression, prevent future attacks? How do you try and modify the disease per se? Disease modifying therapies, disease modifying agents, DMTs, disease modifying treatment or therapies. So now there are two things to keep in mind. Most common one is relapsing. Most common form of MS is relapsing type. So there are certain therapies which have been well studied in relapsing, but in the same therapies may not be effective in the progressive variant. So primary progressive or secondary progressive, you have to have a different approach. Whereas for relapsing, the approach is different because there are certain drugs that have been studied so well in relapsing, but they are not effective in progressive. There's no strong evidence to say that they are effective in progressive, but definitely they have benefit in relapsing. So which are they? Glatiramine acetate is generally the safest drug. So safety profile is great, especially because these are young women, no, 20 to 40 years of age. They may want to conceive. They're married. They want to conceive. So glatiramine acetate is safe that way. It's safe in pregnancy, and the only thing is it is parenteral. That is the inconvenience. But it is available in pre-filled syringes, so they can only inject and they can only use it. So parenteral administration is the problem, but they can be self-injected by the patients. It's a good safety profile. Okay, glatiramine acetate. It's just a combination of certain amino acids. Glatiramir, but it's somehow it's shown to work well. But it has modest. It's not great. It's modest. For mild disease, it's okay. Modest benefit. Next, dimethyl fumarate. Dimethyl fumarate is a prodrug. It gets converted into monomethyl fumarate, and it is shown to reduce the activation of lymphocytes. This is also a good drug. It has good effect, moderate benefit, and otherwise it is oral. But the thing is, it has to be given twice daily. It has the advantage of being oral, but twice daily usage. That has to be told to the patient. And it can have certain side effects, like it can increase liver enzymes. It can reduce lymphocyte count. So yeah, that you have to be watchful about. Okay, and then there is sphingosine 1-phosphate modulators. Sphingosine 1-phosphate, S1P, sphingosine 1-phosphate modulators. They are again oral, so that is an advantage. And they're quite effective. So they are moderately effective also. And again, one thing you have to watch out for is cardiotoxicity, especially electrical. So two drugs in MS treatment have cardiotoxicity. This S1, that means sphingosine 1-phosphate modulators. That is in terms of electrical cardiotoxicity. So they'll end up producing heart blocks and bradycardia. Whereas another one is mitoxantrone. Mitoxantrone ends up producing heart failure with reduced ejection fraction. Okay, so heart blocks. Other things you have to watch out for are the same: lymphopenia and elevation in liver enzymes. These things you have to watch out for. Okay, examples are fingolimod. This is the class of drug, S1P modulators. But fingolimod, ozanimod, these are drugs which come under this class of S1P modulators. Okay. Next, teriflunomide. This is okay. It's modestly effective, and it is what do you say? It is teratogenic. So you have to warn them not to conceive. The ladies, you have to warn them not to conceive when they're taking it. And yeah, safety profile is okay. Apart from teratogenicity, which is a problem. Cladribine, it's an anti-cancer drug. It's again very highly, it's a lymphotoxic drug. Lymphotoxic drug. This is it's lymphostatic. Okay. In terms of teriflunomide, it doesn't kill the cell. It doesn't kill the lymphocyte. It actually inhibits its metabolism. Whereas cladribine is a lymphotoxic drug. That's why it's used in treatment of hairy cell leukemia also. Cladribine is used in treatment of hairy cell leukemia also, because it is lymphotoxic. Hairy cell leukemia is a B cell non-Hodgkin lymphoma, B lymphocyte non-Hodgkin lymphoma. Cladribine inhibits both B and T lymphocytes, both lymphotoxic. Okay, again, it's teratogenic. You have to warn them not to conceive. Very effective though. So moderately effective. So you have to give them cycles of therapy. So you give them roughly 2 cycles in a year, like that, in multiple sclerosis, and you can give it orally also. Okay, that's cladribine. Mitoxantrone, I told you have to watch out for cardiotoxicity, and it is also quite effective, moderately effective. It's like an anti-cancer drug only. Mitoxantrone also. Cardiotoxicity you have to watch out for. It's cardiotoxic, can lead to heart failure with reduced ejection fraction, which means dilated cardiomyopathy. Eventually, it will lead to dilated cardiomyopathy. Cardiotoxic drug can also lead to amenorrhea, permanent amenorrhea in women. So that is also one thing you have to watch out for. If it's a childbearing age or a lady with future plans of conception, can lead to permanent amenorrhea. You have to watch out for that. Okay, and apart from these agents, it's mainly a lot of monoclonal antibodies. Now, ocrelizumab is the best one because it is an anti-CD20 agent, but it is effective in both relapsing and progressive. In fact, it's the only agent which has evidence for disease modifying effect in progressive multiple sclerosis, primary progressive multiple sclerosis, ocrelizumab. Okay, rituximab is also used. This is also anti-CD20. Natalizumab is an anti-integrin, alpha 4 beta 1 integrin inhibitor. So it prevents the lymphocyte diabetes or lymphocyte infiltration into the CNS. So these lymphocytes, sometimes they form lymphoid granulomas, not granulomas, but lymphoid accumulation in the meninges. So they end up infiltrating and they end up producing follicles rather. Okay, lymphoid follicles in within the meninges. So you want to prevent their entry into the CNS. So opposing this integrin will help you to do that. Natalizumab, very effective. But the problem is natalizumab is associated with progressive multifocal leukoencephalopathy, which occurs because of John Cunningham virus infection, manifestation of JC virus, that is progressive multifocal leukoencephalopathy. Because the lymphocyte entry into the brain is being impaired, if the person has a JC virus, it can get reactivated. And that reactivation can manifest as progressive multifocal leukoencephalopathy. Okay. And alemtuzumab is anti-CD52. That is also very, very effective. Alemtuzumab is effective, but it's toxic, quite toxic. It can predispose to tumors. Cladribine is also, cladribine is also, it has a potential to lead to malignancies. Cladribine. So you have to watch out for cladribine-induced malignancies. Alemtuzumab also likewise. Alemtuzumab also has a potential to lead to malignancies. It also leads to a lot of serious infections. So it's toxic drug, very effective, but it has these side effects. And in fact, first time FDA had rejected it. Alemtuzumab was initially rejected from use. Only on a second post a petition by the pharmaceutical, then it got approved. But again, not preferred because of its toxicity profile. Anti-CD2, CD52. Okay, these are the treatments you can use for relapsing forms. What about progressive forms? Secondary progressive, you can again use a certain type of S1P modulator that is known as siponimod. Siponimod. That can be preferred for secondary progressive multiple sclerosis. Primary progressive multiple sclerosis, the best drug is ocrelizumab, anti-CD20. And it doesn't affect the plasma cells which are producing monoclonal antibodies. It affects the B cells before that level. So that is why it doesn't lead to, the side effect profile is good for ocrelizumab. This is the only one which has proven benefit in primary progressive multiple sclerosis. Okay. And finally, symptomatic therapy, depending on each symptom. Spasticity, you can use muscle relaxants, tizanidine, baclofen, basically non-depolarizing skeletal muscle relaxants. For slow gait, you can use delphamperidine, slow gait and weakness. Where else is delphamperidine used? Or 4-aminopyridine? Have you heard of this? Where else do you use it? In which other form of weakness you use this? 4-aminopyridine. Delphamperidine is just a congener of 4-aminopyridine. Okay, and bladder manifestations, you can give solifenacin. These are to try and relax the detrusor. So detrusor hyperactivity, solifenacin, hyoscyamin. These are anticholinergic agents. And for patients who have detrusor sphincter dyssynergia, you can use alpha-1 antagonists like kerosene or phenoxybenzamine, like that. Okay. 4-aminopyridine is used in Lambert-Eaton myasthenic syndrome treatment. Voltage gated calcium channels. Voltage gated calcium channels. It's a paraneoplastic syndrome, no? Paraneoplastic syndrome of CA lung. It's a differential form myasthenia gravis, Lambert-Eaton myasthenic syndrome. Okay, so what else? There are certain things that have shown good promise but not widely used. Hematopoietic stem cell transplantation. Hematopoietic stem cell transplantation has been attempted, shown promise but not widely used. And then that's about it. There's a lot of research going on multiple sclerosis, especially because it affects the Caucasians so much more than us. But we have seen cases, like I told you, that particular patient had MS. It takes a little bit of clinical suspicion to make sure that the person has MS or not. Okay, one question I'll leave you with: primary progressive multiple sclerosis. What is the preferred disease modifying agent in these? Is it rituximab, alemtuzumab, ocrelizumab, or ozanimod? Which one? Excellent. Pratik acid. C, that's correct. So that is the only drug which has evidence with regards to, correct, yes, the drug with evidence for disease modifying activity in primary progressive multiple sclerosis. A lot of times primary progressive multiple sclerosis will affect the spinal cord. Okay, and very frequently it'll present as spinal cord manifestation, paraparesis, progressive paraparesis with posterior column being affected. It'll be a non-compressive myelopathy. So non-compressive myelopathy, and it'll have oligoclonal bands being present, and differential diagnosis is HIV myelopathy. So that's how we had one patient. Patient had progressive paraparesis, and the differential at the time was HIV myelopathy. He was HIV positive also. And it was a man that too, and yet the workup finally revealed that he had multiple sclerosis, and it was primary progressive. It was a long time ago. That time, I mean, even now, ocrelizumab availability is not great, but at the time there were no definite measures for treatment of primary progressive. We tried, but finally he had succumbed. He had retro also. It becomes a very big challenge if a retro patient develops. So you can't use drugs like natalizumab and all, because natalizumab itself will lead to PML, and HIV also, when the CD4 levels are low, it will predispose to PML. Okay, CD4 less than 100 in HIV can predispose to JC virus infection and PML. Okay, but that's how it is. Any doubts? Any questions for today? Multiple sclerosis. Okay, if no questions, we'll end the session here. I'll see you guys again on Wednesday 8 p.m. Okay, thank you everyone for joining. Have a pleasant weekend. Thank you. Thank you. Thank you. Thank you. Thank you all. Okay, I'll end the meeting here. See you on Tuesday.